Hello, everyone. I'm Dhanya Mullassery. I'm one of the consultant pediatric surgeons here, and I'm here to give you a brief overview of our experience doing the TOF MDT clinic and the multidisciplinary pathway, and hopefully getting that bit closer to what Prof. Spitz was describing as what we are treating is not the esophagus, we're treating the child and the parents around it. So we're trying to achieve that holistic approach to TOFs. With me, I have the rest of my team members here, and they'll come up and introduce themselves shortly as well. So in the UK, we have about 150 newborns with TOFs every year. And this graph is a few years old now, but essentially all the dots are showing a center each wherever the surgeries are performed. And down at the bottom, you see the number of operations that are performed in each center. And we are one of the centers with the highest number of newborn TOF repairs every year. And so apart from our newborn TOFs in GOSH, as most of you know, we get the referrals from other centers in other countries, and that adds to our another 5 to 10 recurrent TOFs and complications. So our volume therefore becomes even higher than that. Because of that, we get about 200 TOFs on average at any time in terms of the whole breadth of anybody from newborn to the age of transition. As we saw earlier in Simon's talk, this paper, which actually was led by the patient groups, including EATS and TOFs, gave us that first incentive to say what is actually needed, because this is the first time a big patient opinion was coming out in the press, in the wider pediatric surgical community. The awareness was really raised by this. So 24 countries, patient groups led, working with clinicians, working with scientists. And what this showed was a significant long-term morbidity suffered by children who had by then become adolescents and adults with esophageal atresia, and highlighted how much you need the multidisciplinary care for this group of patients. And then this followed on with lots of guidelines and recommendations, not only from the clinical groups, but also from the patient support groups, such as yourselves. And the most recent one was the TOFS position paper, which came a couple of years ago. And what do all these say? Like Graham said in the beginning, these are where we would like to be. These are ideal. This may be unrealistic for today, but for tomorrow, this is where we want to be. So that's where we want to get to. So with that in mind, we formalized our clinical pathway for all patients with TOF, and that's kind of bringing everything we've heard together, because our pathway takes us from before the baby's born, if they're diagnosed to have esophageal atresia. From the point of that, we meet them with our families, with our multidisciplinary team members. Caroline, standing there with her baby, was one of our lead key people who helped us set this up, actually. So we have all different aspects of it very clearly defined as to who needs to come at which point and what's the support offered to the parent and to the child and to the family, and actually sometimes to the local clinical team who, as some of you mentioned earlier, not every doctor in the UK is aware of esophageal atresia and how much the morbidity of it is, etc. So we are here for you, for your children, for yourself, but also for the clinical teams who may be closer to your home and who may not have as much experience of this as we have. So we then set this up as a pathway, but in this we have specific timelines where we then plan MDT clinics so that all the TOF patients will have an opportunity to go through this, to have the ability to speak to the team as a whole, go through questions and discussions, and have an understanding of what the future holds and what and who to approach when things don't work. And moving on to transition planning and support. So we've only recently, because of COVID and everything, it took us a long time to establish this. Going from May 2023, we've now got this going, and I'm going to have our teams coming and talking to you all about the roles from our different aspects, a little bit about our early reports from our patients and parents, a bit about our future plans, and most importantly, we would be delighted to hear from you what you think about this and where you would like us to do more on this one. So we'll start with my team. I'm one of the surgeons, and you probably met most of the team here, Mr. Curry, Ms. Cross, Professor De Coppi, Mr. Giuliani, and myself. And as Simon alluded to before, we are trying to make our a surgical team, a subspecialist group, so that everybody doesn't do everything. And by trying to, although we have one of the biggest numbers in the country, we still would like to condense that into, a few of us doing a lot of these, so that the more experience we have, the more it is going to be that we know everything about this condition, that when you come and ask us what to expect, we will be best placed to give you that answer. And also with the surgical expertise, the reason lots of places do not want to subspecialize or centralize is because there isn't evidence in pediatric surgery to say that if you do, less numbers or more numbers, it makes any difference. But that's because in pediatric surgery, there'll never be the number of numbers that, for example, if you look in adults, every adult surgeon will have to do 50 gallbladder operations to keep doing that. In children, most of the things we do 3 operations in a year. And, when we say 10 esophageal atresia, it's a big number for us. So there is no talking about numbers in pediatric surgery, but it's common sense to say the more you see, the more you do, the more we have the setup to deliver this, you will see why this works better. I'd like to invite Anya next, who's going to talk to us on behalf of our gastroenterology. Oh, yeah. Gastroenterology department.
Yeah. Good afternoon, everyone. First of all, I'm really grateful I could be here. As a representation of gastroenterology colleagues, I must say we are becoming handy when a patient with TOFOA is having complications, which unfortunately are quite common. And this is only a few, and some of them already were mentioned today, also in Alex's talk before, when we can actually share our expertise and plan investigations or treatment within the same multidisciplinary clinic for the patients. So just a few things from my gastro perspective I would like to mention here. One of them is recurrent anastomotic stricture. We still don't know how prevalent they're in older children or in adults, but we kind of know that they're quite common in the children, and then we can again plan if this is a recurrent situation. What is there anything else in terms of treatment that we could help with, including treatment with the injection of steroids or topical steroids on top of the dilatation. So that's a discussion that we can have together with the surgeons, together with the family, on what would be needed. I think you all know very well about the complications of gastroesophageal reflux, the inflammation in the esophagus, and then later on complications of gastric metaplasia, so-called Barrett's esophagus, when the tissue, the epithelium in the esophagus is changing into more gastric or intestinal type. That's something that we can come across usually in the teenage years or in more adulthood. But again, this is something where we would like to investigate and know what is happening. In terms of the reflux, it's also important now based on the current guidelines and also our discussions, there's a set of investigations that we do between the first and second year of life of child to see if the child will need long-term treatment with proton pump inhibitors, the medications to decrease the acid in the stomach. There are ways for us to assess the reflexes if it's there. If not, because then we can adjust the management accordingly. One of the complication or morbidity is eosinophilic esophagitis. I'm sure you all heard about it. For a reason that is still not very clear, the prevalence in patients with TOFOA is a little bit higher than in general population. And in some, in different studies, it will be between 9 to 17%. Again, that's where we can help do endoscopy, do 3-level biopsy, see if that is the case. And you've heard a lot from Alex about dysphagia and dysmotility. And dysmotility in our patients, this is coming from intrinsic, so congenital problems, but also as a iatrogenic, so post-operative complications. There's not much we can do for dysmotility. There are techniques that Alex will go through with the patient to make the eating and swallowing better, but also for dysphagia, for the information we get from patients, all of us as a team will kind of make it more clear if this is dysphagia that we need to focus from gastro point of view, if the symptoms are more severe because there's inflammation, because there is a narrowing in the anastomotic part, or are we dealing with the dysphagia related to dysmotility? This is where those discussions within the team can actually help a lot to put the patient towards the right investigations or management pathway. So that is my part. Thank you.
Thank you.
We're not done, sorry. We've got more of the team coming through.
I'm going to do this super fast because I know that people are wanting to go. So just my role as a speech and language therapist on the team really is with Dhanya and with Anya to help try and unpick, as I was talking about before, unpick what it is about the eating, drinking, swallowing problems. So our role is to think primarily about the kind of mouth and throat issues, but we can't forget about the esophagus. Particularly in children with esophageal atresia. So we are interested in that as well. So we do it through assessment, through listening to parents, through observing meal times, through using some of those instrumental assessments that I was talking about before. And the goal is really to support development of that optimal oral feeding for the child and the family. So I'm really going to highlight the family bit in that, because as you've heard from Roko and what I was talking about before, it affects the whole family, and so we need to treat the whole family, not just thinking about the child. And then a big part of what our role is within this team is to help support the more local teams, so closer to where you might live, because often they haven't got the same breadth of experience or understanding about esophageal atresia specifically. So we try and support them and help them, guide them once we've figured out where the underlying issue is.
Thank you, Alex. Then we have the dietetic team. Our lead dietitian, Hannah's just about to have a baby in the next few days, so she couldn't come today. But as you can imagine, she works very closely with all of us, but also with the community dietitians who she supports once they don't need the intensive support that Hannah can provide from us. And she works very closely with the SALT team, particularly to give this advice. And then I get Julie to talk about our CNS team, who are the pillar of this team.
Thank you. Hi, I'm Julie. I'm on the surgical anaesthetist. I work as part of a small team. There's 4 of us in our team currently. And we're involved in the care of all the surgical patients, both as an inpatient journey and following discharge right up until transition. We would often, if the family have been antenatally diagnosed, we meet them as part of their antenatal tour, introduce our role, and give them a bit of an idea of what to expect when they come into the hospital. But more often than not, we meet the families once they're post-surgery on the IT unit, just before they transition up onto the ward. We, at that time, will just be exploring how much information they understand about the potential long-term problems with TOFS. For some families, they've done their research, they've got an understanding, they've had discussions with the surgeons, and for other families, they have been focusing primarily on getting through the surgery and that initial post-op recovery, and have no idea that there is potential for any complications. So we gauge that information and we feed that information in according to the parents' kind of needs during the inpatient stay. When they're back up onto the ward, we talk to them about being more involved in their child's care, particularly if the children have got additional needs, the VACTERL type children, if they're perhaps going to go home with a gastrostomy, making sure that before they get home they're confident in managing all of those cares. And we are mindful that the psychological impact of having a child with TOF on the family. So at this time, we often signpost them to psychosocial support. We've got a fantastic psychology team, social workers who can encompass family support workers, can help with disability living allowance applications or financial support just from that initial admission stay, because we appreciate, certainly being in central London, it's an expensive business being in hospital with your baby. And often at this time we signpost families to the TOF charity because they offer what we can't, and that is the opportunity to not network with other families that have got that shared experience. We can provide all the information that we can, but we can't give them that. So that's something that we find really valuable, and certainly families have kind of fed back. So it's something that they really appreciate, the opportunity to use their Facebook page to network with other families. Before families are ready to go home, we would be making sure that they're aware of what to look out for when they're home, the potential issues. So we're talking about reflux, the potential for developing a stricture and recognising what that would look like. Potentials for respiratory infections and recognising when there's a change. And the most important thing is really recognising how your baby looks now, what's normal for your baby, and then recognising any changes and then where to go to for that. As part of that, we do some emergency life support training, and we talk about choking, because we appreciate that these children are going to be a bit more vulnerable, particularly when it comes to weaning. We would refer to a paediatrician and again share any information. We're mindful that not all professionals have got the experience working with TOFs as we do, and the same goes for GPs and health visitors. We often share the information that is provided on the TOF website, and just basic TOF related information. Once families are discharged, we will keep in regular contact with them. So it will be initially weekly phone calls, and then we'll kind of wean that off according to the child's needs. So for children that are coming backwards and forwards for regular dilatations or having issues with reflux, we'll keep that going for as long as necessary. But we'll always be that point of contact for a family. So even if we've not engaged with them for a year, they know that they can reach out to us if they have any concerns. And we use that opportunity to hopefully avoid families having to be admitted locally inappropriately. So if there's a developing stricture or symptoms that they're worried about, they can talk that through to us. We can work out, do they perhaps need a contrast study to have a look to see if there's developing stricture, or are we confident that actually this is what's happening? We can go straight to planning a dilatation and they can come in directly to us rather than have to go through the rigmarole of going to the local A&E, waiting there, having to sell their story to the local teams and whatnot. So it just makes the journey a little bit easier for these families. Children are often seen in clinic just ahead of weaning, and once they're given the go-ahead by the surgeons that they're happy for them to head on with weaning, then we would have a telephone clinic with them. And we would just talk through the kind of practicalities, how to do it, and how to even particular foods that are easy to blend, foods to avoid, and whatnot. We've got some written literature that we've developed with our speech and language team and dietitians, and we share that and offer at that time we might be signposting them to dietetics or speech and language for any additional support as necessary. And then finally, when children are at the stage when they're ready to go to nursery or school, we will offer our services to provide any teaching. So we always encourage parents to have that initial conversation, but it can be helpful for us to share generic TOF information, and often we set up Zoom calls with the carers that are going to be looking after them in school, just so they're aware of what issues they can have, what's normal for them, when to worry, when not to worry, and if children have got complex needs and they need an EHCP, we can support in that process, providing all kind of necessary letters and whatnot. And I think families have found that certainly valuable, and that continues right through to primary, secondary school, for whatever families need, and up until transition, although that's a process that we're working on, and we're going to talk about that a bit more.
Thank you, Julie. So this is just a photo that we forgot to take one in the proper full clinic. So it's just as after the parents left in this month's clinic. So this is a setup. We all sit together and have a discussion before the patients come in. We've got half an hour with the patients so that all of us can be given any questions that the family has. The benefits, what we found is that this is an assessment in real time. The parents have this opportunity to talk to all of us together. There was some things that came up about mixed messages that can come from various professionals, even within one team. And it's really important when we are actually able to talk to parents together so that they can actually then say, why is it slightly different, that sort of thing. So we can go with a joint message about what the plan is for the child. Obviously, it also, the little things like avoiding multiple clinic visits, coming into London every other week is not really the best idea. And therefore streamlines the patient's journey. This is just a short feedback we got this month. We've just got 7 responses from our parents that we asked for. And our general themes that came up was very useful having multiple members of the MDT in clinic, and parents feel like this is the way to go, really, rather than having to come to different sessions to see each of us. And they felt that any concerns that we had, not just about an esophageal stricture, but it's, as we said, the whole child and all the concerns about what next, all of those, is able to be addressed and listened to in this context. They feel confident about making a future management plan together, and therefore all of them would recommend that such a multidisciplinary clinic setting to other parents. So we're working on strengthening the transition support, widening input for select clinics. By this, I mean teams who work with us when patients are inpatient. So there are some that we send to their outpatient clinics still, like the respiratory, which is very key, psychology, another team, ENT, airway and cardiothoracic. So there are specific instances and some select group of patients where they would also be very useful to have in a clinic. So we might be looking at having those teams in 1 or 2 times a year and bring particular patients into those, so that again the whole picture is easier for the family to understand. Moreover, we talked about having outcome sets, core outcomes, etc., that we can then hopefully bring through the patients in this clinic, and we can also then give that information back to our own patients to say this is what our patients are doing, this is what you can expect, and not have to base it on just anywhere. This is based on the patients that we've had in our experience with the surgeries that we do, that sort of thing. And this can be set up anywhere pretty much. So it's a very practical thing to do now. We don't have to wait for anything to happen in the future. So a key thing that I know is all top of all of your minds is what happens at transition, and this INOIA guidelines recommending very specific things, which would be ideal as we move into the a transition adolescent and adult world. This is going to take some time, and I'm not saying we can do as pediatric TOF team. We may not have much of a say into a lot of this, but maybe if we can just set things up to get these children safely into adulthood, then they can have their voice, and your voice is heard by knowing what it is that they need. They will be able to speak up for themselves, is our hope.